is just a huge honor for me today to be podcast interviewing Dr. Dania Tamimi, BDS, DMSc, graduated with a dental degree from King Saud University in Riyadh, Saudi Arabia. She trained at Harvard School of Dental Medicine and earned a Doctor of Medical Science, DMSc, and certified of Fellowship in Oral and Maxillofacial Radiology in 2005. She is board certified by the American Board of Oral and Maxillofacial Radiology. She is a reviewer and editorial board member for oral surgery, oral path, oral medicine, oral radiology, or just go 4000000, as well as a reviewer for DMFR, oral radiology, head and neck, angle orthodontist, AGO-DO. She's a lead author of 2 textbooks, Specialty Imaging, Dental Implants, which has been translated to Portuguese and Russian, and Specialty Imaging, Temporomandibular Joint, translated to Spanish, and a co-lead author on Diagnostic Imaging, Oral and Maxillofacial, translated to Spanish. She lectures nationally and internationally. She currently runs her home-based Oral and Maxillofacial Radiology private practice in Orlando, Florida, and is the mother of 3 children, which is amazing. You basically 3 books and 3 children. I bet it took longer to write those books than it was to have a baby. Oh my gosh, I am so excited to have you on here. I'll never forget when I upgraded my pano to a 3D Cbct, and we took our first image, and there were 3 of us dentists looking at it, and we'd all practiced for 20 years, and we were looking at that. It looked like some picture from the Hubble Space Telescope, and we didn't even know what we were looking at. I mean, I couldn't believe 3 old doctors were looking at these spots, and I mean, we weren't even close. I just want to thank you so much for coming on the show today. How are you doing?
I'm very good. Thank you so much for inviting me. It's an honor and a pleasure.
Well, was I right? It takes 9 months to make a child. Did it take longer than 9 months to write a book?
A little bit longer than that. One of them took about 18 months. Actually, 2 of them took about 18 months and 1 took about 10 months. So, and it is very similar to gestation, by the way, the whole like book writing thing. You know, you have the beginning and this thing that grows and grows and grows and grows, you know, and then there's the final like relief at the end when you deliver the thing. And and then when you hold the baby in your arms for the first time, it's great. Same thing with the book. You know, when you see it in print on your doorstep, it's just an incredible feeling.
Now, I read on the internet that you were one of the first oral and maxillofacial radiologists to practice teleradiology. What is teleradiology?
Well, basically what that means is that I live here in Orlando and you are in Arizona, and you acquire your cone beam CTs and you would send them to me via the internet for me to interpret. I'd write my report and I'd send it back to you. So basically that's what it means. It's bringing me to you or bringing you to me. I'd rather be brought to you so I can go on vacation, but that's basically how it is. It helps you connect with a radiologist, even if there isn't a radiologist close by.
You know, before this is Dentistry Uncensored, so I want to talk about everything that no one else wants to talk about. But so let's start with because these kids are in school and they have to know the opposite view of this. Some oral radiologists are saying that we dentists are taking too many of these. So before we get into what it is and how to read them and what to look for and all that stuff, I'm going to start with the kids. When should you actually take a CBCT? And I mean, should every molar endo require a CBCT 3-dimensional? Should every parent who says, hey, when my little Billy grows up, will he need braces? Does that automatically mean get a CBCT? Because I had an oral radiologist on this show, and she was she said she was equally pleased by the advancement of the technology, but equally displeased at too much radiation on too many people. I'm sure you've heard that before. What are your thoughts on that? So when do you take a CBCT?
Well, you have to precede any kind of radiographic examination with a clinical exam. You know, you can't just scan or image every patient that comes through the door. You have to examine them clinically. You got to see what's going on. And depending on what they need, you may choose to acquire a cone beam CT or not. It's certainly not one size fits all. Some people don't need a cone beam CT, but probably need a periapical or a bite wing or a pano. Some people might need a smaller field of view. Some people might need a larger field of view. It depends on the clinical indication, why they walked into your clinic and what are they exhibiting in terms of their phenotype and their symptoms. So yes, a lot of dentists are scanning patients, sometimes as money-making, as a money-making gimmick. So basically they're trying to sell treatment plans with cone beam CT, and that's not right. But what they should be doing is examining the patient first, seeing if they need that kind of imaging or not. So
do they have anything that's perfect for an endodontist, small field of view, and an orthodontist, large field, 2-in-1?
Oh, well, 2-in-1, I don't know about 2-in-1. Okay,
well,
so
I mean, something that would please an endodontist for the small field, just a molar, and it'd please an orthodontist for the large.
Well, one single machine that's going to do both, please both, and be ideal for both? No. Okay, because there are there's some physics that goes into it that, and I don't want to go into physics because I don't want to bore your audience, Oh,
I love physics. It's, I don't know, it is my favorite subject. I mean, math. So when people say math is their favorite language, I'm like, okay, math is a language. Like we're talking English, math is a language, but the first language to talk about with math is physics. But anyway, but still at 2020, there's not a perfect solution from endo to ortho.
Oh, I mean, you'd have to know what your treatment, basically, what is the population that's walking through your door. If you're an endodontist and all your patients are endodontic patients, then obviously you're going to have to acquire the type of imaging that is required to diagnose these patients, properly. So you would need a smaller field of view, a higher resolution. Smaller field of view, meaning that you don't need to see everything else in the mouth if you're just doing a root canal for tooth number 3, for example, right? But if you're doing orthodontics, if you're treating the TMJ, if you're treating the airway, any of that stuff, that encompasses more of the craniofacial structures. That requires a more comprehensive evaluation of the craniofacial structures. And that's when you would get you would choose to purchase a larger machine,
So people send you their x-ray. So someone's already thinking, how would they send Dania Tamimi a CBCT? Do you have a website or what's the website you go to?
Yeah, I mean, most of us who are engaged in teleradiology have either a company that they work with or they have their own little business going on. Because I'm really busy with my kids, I haven't set up my own business. So I work with beam readers. I don't know if you're familiar with them or not.
Absolutely.
So yeah, and they have, I think, about 30, 40 radiologists now, and all over the US and some internationally. And they distribute the load according to, the licensure issues and, who has a license in what state and whether the state allows like open commerce, interstate commerce, let's put it that way. Yeah.
And so you would go to, and this is not a commercial, nobody's paid me any money, but if you want to send me a bottle of Jameson, I won't return it in the mail. So Beam Readers is just beamreaders.com.
Like cone beam, the beam from cone beam. And readers.
So I would, so what do you make an account? So you go to Beam Readers and make an account, and then you upload that over your internet.
Right. So basically, I mean, and I want to make it clear, I work with them. I don't work for them. So I'm an independent contractor. So I don't make any money off of this either.
Is that a pretty big file? I mean, is that like downloading a movie, sending a CBCT? What kind of time does it take to upload and download a CBCT?
I mean, it requires a good bandwidth, good internet speed, high.
But when you go to read it yourself in Orlando, when you download the CBCT, how long does it take you to download it?
Not very long. We've got a really good connection here.
Nice,
both my husband and I are radiologists. This is where he usually works, right there.
Your husband's a radiologist too?
Yeah.
Now, is he dental or what?
No, he's medical.
He's medical. Huh, interesting. And you're You're very medical. I mean, you don't sound like a dentist at all. I mean, everything in your books, everything about you is that you firmly believe it's one body, all completely related. And I still don't even like the DDS DMD thing, let alone the DDS to MD. I like the Russian system better, where you start off, everybody does the same undergrad, they do the first 2 years, but when you go to declare a specialty, you could go into dermatology, you could go into OBGYN, or you can go into stomatology. And what I like about that is the flexibility that if a Russian dentist can't use his hands and do surgery anymore, well, he just folds back into the medical system, and you find him 2 years later, and he's, family practice medicine or something. Do you, and then for the consumer in America, so many people keep asking, I mean, I've heard it for 33 years. Well, what's the difference between a DDS and a DMD? And I'm a DDS, so I just tell them a DDS is a real doctor and a DMD is just some fake wannabe, probably got his license on eBay or something like that. And but you're very holistic, aren't you?
Yeah. Well, I am a dentist. So my background is dentistry. My degree is a BDS, which is a Bachelor of Dental Surgery, which in places other than the US and Canada, we go into dental school or medical school straight out of high school. Okay. So the first university degree that you acquire is a dental degree. But you're still called a doctor, even though you have a bachelor's degree, which is great. But I went a step further and acquired a doctorate of medical science while I was doing my radiology residency at Harvard Medical School, or Harvard Dental School, sorry. Harvard School of Dental Medicine, that's what they call themselves.
That was, congratulations on getting in. I applied to Harvard Dental School, and they filed a restraining order on me. To actually get in, that's an amazing feat. How many people applied for how many seats? Did you ever get the lowdown on that? Oh, must have been.
No, not for that. That residency, radiology isn't as desirable as surgery, for example, or orthodontics, because we don't really, as a radiologist, one does not really make that much money when compared to orthodontics and surgery and the other fields. But the quality of life is fantastic.
You said it doesn't make much money, but let's be frank, you made a fantastic decision. You married a radiologist too. That's so, but I always, let's be frank, I always see that with women doctors. Women doctors always marry male doctors, bankers, lawyers, successful people. And so many of the male doctors always marry the waitress from the Waffle House. I just think I seriously think females marry far more intelligently than their male counterparts in school.
Well, he's a good guy. He's a good guy. Yeah,
well, that's great.
Nothing to do with him being medical.
But he's a successful, independent, highly educated person. Mm-hmm. And when you say successful, highly educated, independent person, those first three adjectives just erased half the wives that all the men dentists married on planet Earth. Let's just start with the deal. What motivated you to write 2 books? I mean, where does that come from? Did your mom, dad, and grandma and grandpa come from a long line of book writers, or?
Well, there is. My grandfather was a writer, but I don't think that has anything to do with this. So I do like to write in general. I've always loved, editing newsletters and school newspapers and things like that when I was in school and dental school. And I enjoy reviewing. As you might have noticed in my bio, I have a lot of journals that I review for. The thing about the books that I read, when I first entered the field of oral radiology, and actually it started when I met my husband. So we met in my second year of my residency, and he is like I said, a medical radiologist. And when we met, he asked me what I did. And I told him, well, I'm studying to be an oral and maxillofacial radiologist. And he's like, what's that? So the fact that a medical radiologist had no idea what an oral and maxillofacial radiologist was, that set off some light bulbs in my head. I mean, this is an area. I mean, we basically treat the same people. We're dealing with the same people. We're diagnosing the same scans. It's just, we don't crosstalk and we don't understand what each of us do. So I started going to a conference with him called the Radiologic Society of North America, which is a huge radiology conference in Chicago every year. Of course, with COVID, there isn't going to be one this year, but it's fantastic. And that brought me together with a lot of not only general radiologists of all walks of life, but also head and neck radiologists. So thinking that the head and neck radiologists would know a little bit more about the dentition and the jaws and that kind of thing and the TMJs. I attended some lectures and this is what I heard one of the presenters there say. He was talking about the teeth because they look at teeth too when they're reviewing oral cavity on their scans. And they have to, of course, name the teeth or number them or whatever. And here's how he named them, the medial incisor, the lateral incisor. So even the nomenclature was incorrect, So I started to slowly infiltrate into their society, the American Society of Head and Neck Radiology. Not infiltrate like a bad thing. I would attend the lectures, I would attend their meetings. I started giving lectures at their meetings. I actually give lectures every year now to the medical head and neck radiologists to teach them basically how a dentist looks at things and what a dentist needs from them. If they ever need to evaluate a TMJ scan or an implant scan or anything like that, what is it that they need to be thinking of? Because they're not taught to think like us, the directions around the teeth. I mean, that's like Greek to them, the mesial distal, that kind of thing, to describe things in relation to teeth is just completely foreign. Because they're working with the anatomic, medial and lateral and anterior, posterior, craniocaudal or superior, inferior. So describing things in relation to teeth is something that they have to be trained to do.
Well, I'm curious if you were sent 100 CBCTs to read for dentist, mm-hmm. What would they be? I mean, you go to McDonald's, it's a hamburger, fry, and a Coke. What is the hamburger, fry, and a Coke? You keep saying TMJ. Is TMJ the biggest, most weighted percentage of CBCTs you get, or are they endodontist or,
No, for me it is. For me, because remember, I mean, the population that asks me to read their scans are mostly orthodontists, TMJ specialists, and airway, people who are doing airway stuff, who are treating or dealing with sleep disordered breathing. There are many other radiologists in our group who do a lot more endo, who do a lot more implants. So, I would say currently, if I were to look at my queue and tell you how much I have from each specialty, I'd say a good 70% are people who are asking me to evaluate TMJ, airway, orthodontics. I actually have a chiropractor that sends me scans as well, so cervical spine, okay? And, but that's my practice. Like I said, many other dentists, many other radiologists have pathology. I do get pathology as well, but certainly not as much as the TMJ stuff. And, here's a little thing about evaluating the TMJ. Evaluating any of these 3 things or 4 things that I just mentioned, it's all the same reporting. It's all the same evaluation because it's all connected. Your teeth don't live in silo, don't live in space. They're actually connected to jaws that are connected to the skull base, that are connected to the TMJ, that house the soft tissues that may spill into the oropharynx in a sleep apnea episode. The maxilla is, the roof of the maxilla, the palate, the roof of the oral cavity is the floor of the nasal cavity. So anything in terms of the changes of the shape of the maxilla inside the maxilla can affect the dimensions of the nasal cavity. All right.
You just really, the quality of what you do is directly proportional to how well you know anatomy.
Oh, of course, anatomy is king. I think anatomy is king in anything in dentistry or medicine. If you don't know anatomy, then if you don't respect anatomy, then you're going to get in trouble, you know. But particularly in my job, anatomy is the thing, the central knowledge in a radiologist training is to know what is normal, to know, also the variations of normal, so that if you see something that is abnormal, you can pick it up right away and talk about it, and tell the referring clinician about it. So absolutely, anatomy is king. And I did a lot of dissections, a ton of dissections in my early years. I used to do one every year, and now I'm doing one every other year. Unfortunately, this year I won't be able to do it because of COVID, but,
when you study, do you always find studying the trigeminal nerve to be nerve-wracking?
Not radiographically. Oh. It's actually quite simple radiographically, but yes, the nervous system and the vessels and all that, of course, on soft tissue imaging, like if you were dealing with an MRI of the head and neck, which is what most head and neck radiologists will look at.
Well, I really wanted to get you on so these kids, I hope it makes a lot of them get your textbooks and read them, because in oral radiology, I imagine it's far less controversial, and everything's far more known in molar endo and probably ortho than the three areas you went into: TMJ, sleep, airways. I mean, that's all pioneering stuff. I mean, TMJ. I mean, you couldn't get two dentists to agree on TMJ if they were drinking. I mean, it's just that's my gosh. So, in fact, when I got out of school in 1987, the word sleep was never even mentioned. I mean, it was never brought up all the way through graduation. And TMJ surgeries, I remember there was a big feud at our school because the oral surgeons were surgically treating TMJ with surgery, and a few of the lecturers in the class would openly call them butchers. And I mean, that's not very respectful when you're calling your colleague a butcher, but it's been controversial my whole life. TMJ, is it getting less controversial? Is it getting more to be an exact science as opposed to a lot of theories?
Well, I think that there's certainly a lot more respect for the TMJ and how the TMJ affects the occlusion, affects your bite, which is basically how your teeth come together, and affects the growth and development of your mandible and your face in general. So are you going to have like a straight profile, or are you going to have a convex facial profile? Is there going to be unfavorable growth of the mandible because of degeneration of the TMJs? Or there going to be an asymmetry because of a degeneration of the TMJ or other pathology? And if that mandible does grow backwards because of the growth sites here that drive the growth of the mandible, if they're defunct because they're broken down and the mandible goes backwards, then the tongue that's attached to the mandible is also going to go backwards. It's just, and yes, I mean, unfortunately in dental schools, we're not really taught these relationships. We're not taught to respect the complex. We just do our class 1s, class 2s, class 3s, our crown and bridge, preps and all that, but, and I went to a really good school, but unfortunately, the TMJ wasn't really given the weight that it should have been. And it's hard. It's not easy. I mean, it's hard for anyone because you're dealing not with just one joint, you're dealing with two joints that work together, that articulate with the skull base, that change the way you function, the way you do anything with your mandible. I mean, anytime you open your mouth, you use them. So certainly, and there's still a lot of controversy on how to treat a TMD, whatever the TMD may be, because temporomandibular disorders can be muscular, they can be osseous, they can be, whatever. There's so much so many diagnoses that you can have for a temporomandibular disorder. And there are different philosophies as well. And people who treat the TMD with splints, some people who treat them with orthodontics, specific types of orthodontics, not just like whatever. people who look at the TMJ and the airway as a continuum and treat one and the other together, and rather than separately. So yes, there's a lot of infighting between these groups because everybody thinks that they're right. But the way that I see it is that this system is so unique. It's so important. Anytime you open your mouth, just like I said, to eat, to drink, to kiss, to whatever, every time you move your mandible, you are using your TMJs. And I believe in God, and I believe God created it with this incredible ability to heal itself. So it's a very adaptable joint. And in order to maintain life, in order to keep these functions that are important for us. So do people do certain philosophies treat TMD? Partly, but I think that the TMD itself is the TMJ itself is so adaptable that it takes a lot to help to break it down, and it's just screaming to be helped, in my opinion, so.
Well, yeah, I always, what I learned is, TMJ stands for Temporomandibular Joint, but TMD stands for too much detail. I just would send the film to you. In fact, do you, what is it like on a day? Do you have like a Cbct that someone sent you that you could pull it up and show us what a day
sure.
for Dania is like?
A day for Dania, even after sending the kids off to school. Well, the commute from my bedroom to my office is like 5 steps, so maybe 10, if I'm walking baby footsteps. So it's great. I mean, I work from home. I've always worked from home, and it's just great for any woman who has children who wants the flexibility to travel and that kind of thing. But in the normal, in my normal life, first I would, of course, download the scan from the internet and I'd open up a report, and I'd use my software to view this. And I'm going to share my screen with you right now. Let's see if this pulls up. And okay. So do you see my screen?
I do.
Okay, perfect. So I would get the images and
hang on one second. If you're listening on iTunes, switch over to YouTube. Just go to youtube.com/Dental Magazine because she's showing a video. But you might want to talk as if they were listening on iTunes too. So you might want to explain this for sound. Explain it to me like I'm Stevie Wonder.
I wouldn't trust Stevie Wonder to read a cone beam CT. Okay, so
if you have an iPhone, it will appear as Braille on the screen. So I don't know if that works on an Android or not.
All right. So basically, what I have on my screen right now is my software. The software that I use is In Vivo by Anatomage, and I have the cone beam CT data displayed in 3 planes. Okay, it's called a multiplanar reformat, and I'm pointing to the axial, and pointing to the coronal, and I'm pointing to the sagittal. So these are slices that are along these planes, these anatomic planes: the axial, the coronal, and then the sagittal. Okay. So when I look at these scans, I make sure to use 2 parts of my brain, okay? One of the most common afflictions in dentistry is tunnel vision. And as a dentist, I am a dentist first. So of course I notice people's teeth, when I meet them. And it's the same thing here on radiographic imaging. Our eyes tend to go to the things that we like. And we look at teeth, we look at the area that we're trying to treat, we go straight to that area, gravitate to it. So I try to turn that side of my brain off, the dentist brain, okay? And I'm going to turn the radiologist part of my brain on, okay? So radiologist brain is very similar to my head and neck radiology colleagues, which is basically look at the anatomy and make sure that there's nothing abnormal on the scan, okay? So I'm just going to show quickly, not going to go in too much detail what I do, all right? How the methodology of going through a scan, okay? So I'm going to start from the top of the scan as such, And because there's just so much anatomy here, I try to simplify it. I try to break it down. Okay. So I look at the black things first, and the black things are things that are filled with air. So those would be the sinuses, the air passages, and whatnot. And the trick here is to look at one anatomic structure at a time. So you don't want to have your eyes flitting to a bazillion places at the same time, because then you're going to miss stuff. Okay. So using that methodology, we're going to look at the black stuff. Let me make this a little bit bigger right here. And as I'm scrolling, I'm looking at the ethmoid air cells as they're starting to appear. Okay. And the ethmoid air cells are a group of sinuses that we have. So these are the sphenoids. I'm not going to look at those now, because I want to look at one anatomic set of structures at a time, and scroll all the way to the bottom of that, and then go all the way up, okay, to the top, and look at these areas, which are the sphenoid sinuses from the top to the bottom. Okay. So I just do that for every single air-filled space, the maxillary sinuses, the nasal cavity going from the top to the bottom, sure that my eyes don't go anywhere else, just keep it here, keep it focused on the one anatomical structure that I'm trying to look at. Now I'm going to look at the nasopharynx going from the top all the way down to the bottom, and it's contiguous with the oropharynx. So I'm going to scroll my way down, and notice how small the airway is. Do you see how little it is? It's like a straw, a teeny straw. Okay. This oropharynx is traveling all the way down. Okay, and that's the epiglottis, and that's the bottom of the scan. All right. So now I'm going to climb my way up and look at the bony things. So I look at the air-filled things. Now I'm going to look at the bony things. So scrolling up through the cervical spine. Okay, I see some degenerative joint disease right here, and then scrolling up, going all the way up, coming into the skull base. And this is where it gets really tricky. And this is where the anatomy is very important to know. Okay. Here's the occipital condyles, foramen magnum. And it's an exercise in cranial nerves from 1 to 12, only in reverse. So looking at all these foramina, I'm not going to name them. I'm not going to, tell you this is this or that. I'm just letting you know that I'm looking at every single anatomical structure in the skull base, as well as in the cranium itself, making sure that no calcifications in the areas of the carotid arteries or anything like that. And that's basically it. And I do that in the 3 planes. So I'm not going to repeat it, but I'm going to do the same thing here and on the coronal, and I'm going to do the same thing on the sagittal. Okay. On the sagittal is where I start to look at teeth. Okay. And we start from the right side. Of course, I know which side is the right side right now, but I'd like you to look at these teeth and notice the sclerosis in the periodontal bone. Okay. So I noted the airway being tiny. I'm looking at this sclerosis. Let's keep going. And I'm noticing that there are these exostoses. Okay, so another finding. So I'm connecting the dots, trying to find the clues to what's going on with this patient. Okay, scrolling all the way around, checking the teeth from 1 to 16. Okay, and I do have a little bit of sclerosis here on 14, and also a little bit on 15 right here. And then I'm taking it back from the area of 17, 18, and the bone looks a little sclerotic here as well. Okay, scrolling, and I can still see those exostoses as I go all the way to the other side. Okay, I don't see any pathology. All right, so now I'm going to take the radiologist. I'm done with the radiologist. All right, now I'm going to go into dentist. So as a dentist, our comfort zone is the pano. So I create a pano, and I'll just look at the general appearance of that mandible, a general appearance of the anatomy. And I noticed something about the position of the condyle in the fossa. Okay, I noticed that it's a little bit inferiorly positioned. That's an interesting finding. So I'm going to write that down. And then, so let's take a closer look at the TMJs. And in these TMJ cross sections, I do see that the condyle is inferiorly positioned as well here and here, as you can see. All right, so these condyles are not completely seated in the fossa. Okay, it's not in an orthopedically stable position. So let's check if the condyle is out of the fossa, are the teeth in maximum intercuspation? Okay, let's take a look at the volume rendering. So yes, it looks like the teeth are in maximum intercuspation. Okay, teeth are in maximum intercuspation, but the condyles are not seated in the fossa. All right, so my findings so far are small airway, condyle inferiorly positioned. I see the teeth in maximum intercuspation. I see the tori. I see sclerosis in the periodontium surrounding the molar teeth. The maxillary curve of Spee is relatively flat. Okay, so all this stuff together, let me look at the airway and just see how small it is. Okay, just to get a sense of where I am in terms of numbers. I know, I mean, dentists like to measure things. I'm a dentist and I understand, but really with these airway measurements in on cone beam CT, they're not very reliable because we have this, because we have the airway is a collapsible tube and it's governed by the position of the hard tissues as well as the position of the soft tissues. Okay. But on this scan, I see that the minimum area diameter is less than 50, okay? Even though the head is forward, look at this. The head is forward, the cervical spine is extended, and that's because on cone beam CTs, that they're usually like positioning devices, and in this case, it's a chin stop, as you can see right here, okay? So putting all the stuff together, all right, so what happens? This person, even with this head forward, has a small airway. And if you try this with me, Howard, if you'd like to try this little exercise with me, okay? If you're, just bring yourself into a neutral position, like sit up tall, okay? And take a deep breath in and out through your nose. Okay, and now I'd like you to move your head forward, just like move it forward, just keep your shoulders where they are and just move your head forward and take a deep breath in and out through your nose. And then move your head back like that. Okay, just like protrude your head, yep. And take a deep breath in through your nose. So what do you notice about the ease of breath? Which one was the easiest to breathe through?
Forward.
Yep, because when you move your head forward, you open your airway dimensions. So one of the things that human beings do in order to protect their airway is to move their heads forward to open up the dimensions of the oropharynx. So that's one protective mechanism. Another one is to move the mandible forward. Okay, so when you move the mandible forward, you're moving the soft tissues that are attached to it forward as well, the floor of the mouth and the tongue. All right, and that kind of opens up the airway as well. So let's try to put this whole picture together. So I'm going to bring it back to this 3D. And if you look at this patient again and put all the pieces of the puzzle together to make the story, what I suspect has happened with this individual is that he has a compromised airway. One of the protective mechanisms, like I said, is to move the mandible forward. Okay, when you come into protrusive or a little bit anterior of your maximum intercuspation, what happens is the condyle will drop out of the fossa, okay? And over time, you can have a super eruption that occurs to the teeth. So a dual bite is formed. So this guy has two bites. He has a bite that is, you know, where the condyles are seated in the fossa, which is not what we have here. And he has the bite where the teeth are in maximum intercuspation, the condyle is not seated in the fossa. Now, what may happen with time is that these condyles are going to sink back into the fossa. They're going to creep back into the fossa. And when they do that, the mandible is going to rotate and there's going to be an anterior open bite. And there is evidence on the scan of a traumatic occlusion. One of them is the exhaustoses that we saw, and the other is the sclerosis around the area of the molars, okay? So when I write my report, I talk about all these things. Of course, if there are dental findings in terms of periapical disease, caries, whatnot, periodontal disease, I'll talk about that. But I try to put the whole picture together so that the clinician sees what I see And then they can go back to their patient and they can evaluate them for these findings. And of course, the clinical evaluation is more, you have to use the clinical evaluation to verify these radiographic findings. Because in the end, what I'm doing is I'm looking at a static image at one time point. But hopefully that there are some clues that can help the clinician when diagnosing and treating their patients. So it's a diagnosis of the entire system rather than one tooth or a few teeth, So that's my spiel.
That is just amazing. I mean, that is now you have 3 children, right?
Yeah.
So do you if you practice proper parental supervision, you should teach them radiology, then they can actually have supervision.
Supervision, right? 3D vision.
3D. There you go. You'll go from supervision of your children to 3D vision
or X-ray vision.
So basically, you're getting mostly TMD. So what are you what are you mostly seeing in TMD? I mean, I'm a believer simply because one time this patient, she was young, she was fine, she was healthy, but she kept complaining, and I had just bought my new Cbct from Carestream, and I thought, well, let's go take a peek. And sure enough, she had like this little granular ball, in her. But anyway, so luckily, and I'm in a big city, so I could refer her out. But what are you looking at where you say, no, she doesn't have this, or yes, she definitely has this? I mean, what does a typical case look like to you?
I mean, thankfully, most of them are relatively normal. A lot of people do have disc displacements. So I don't see the disc displacements on cone beam CT, but I can tell that the soft tissue isn't where it needs to be because the condyle isn't in the fossa where it isn't seated in the fossa. The condyle would be either superiorly positioned, posteriorly positioned. The space that the soft tissue of the disc would inhabit between the condyle and the fossa is diminished. So that tells me that there is a disc displacement. And I see a lot of that in the human populations that I see. Not that I see in other populations, but I also see many patients who have narrow noses and narrow transverse dimension of their maxilla. And it kind of makes me think what's happening, that this is now rampant. You see a lot of people with narrower faces and narrower noses, not like the external nose, but the actual nasal cavity, the bone that encases the lumen of the nasal cavity. The transverse dimension there would be narrow. And maybe it's our diet, maybe it's, because there's a big generation of children that were not breastfed. Maybe that changed, the development of our faces, the development of our maxilla. Like I said, the maxilla and the nose, they basically share that wall. So in terms, like I said, these are the most common findings that I'll see. Okay. Once in a while, I'll get some pathology. I'll see, tumors or there's a lot of dental stuff as well. Like I said, periapical, periodontal. But most of the patients that I receive don't have that issue. They're orthodontic patients or, their teeth are, or the dental condition isn't that bad. Yeah, I mean, what else can I tell you?
Well, I want to, first of all, made me think of so many things. I'm convinced, I'm not an anthropologist, but I pretend to be one sometimes. I love anthropology, and in business, you read, and when I was in MBA school, they talk about all the time about the reason it's so important for all the departments to be transparent is because everybody within the department gets tunnel vision and drinks the Kool-Aid, and it's usually someone from another department that says, I don't understand what they're doing next door. It seems like it doesn't make sense because of blah, blah. And then everybody looks like, holy moly, you're right. And no dentist ever brought this to my attention, but the anthropologists were publishing stuff saying, why don't we see all these malocclusions just dropping back to a 200-year-old human, let alone a 5,000, 10,000 million year old. And it looks like a lot of it correlates with going to a diet of mush. I mean, and we're not chewing on the leg of a stegosaurus. We're, we're not taking down a woolly mammoth. We're actually just eating mush. And then the bottle too. I read a study on this where the amount of force it takes to nurse. I mean, the amount of effort versus these bottles where, it just comes guzzling out. And so,
been there, done that.
So it's obviously
a different mechanism.
Yeah.
It's a different mechanism.
So when you look at hell, let's just go back to 500 years. When you go back 500 years all the way back and you don't see any of this stuff, and then today you see it everywhere, well, obviously something's changed, and it's changed during the growth and development. So yeah, I think baby bottles, pacifiers, and feeding kids mush out of a jar is a big part of it. But I want to go to your book. Let's go to the first one. This one was Specialty Imaging, Temporomandibular Joint by Dania Tamimi on Amazon. I posted this on Dental Town under TMJ. And you go through the extensive normal versus abnormal temporomandibular joints and how those look on radiographic imaging. But I want you to go into the hot topics of understanding the temporomandibular joint through biomechanical engineering, structure, function of the TMJ joint in normal and pathological joints, and clinical radiological correlation of temporomandibular joint findings. Because I have, as I own a media company, I own a magazine since 1994, and my gosh, very rarely do I publish an article on endo and get a big backlash. And that was only one time. That was Scott Perkins, who wrote an article called The 15-Minute Root Canal, and I literally thought both of us were going to get killed. But my gosh, when they submit an article on TMJ, we send it to our reviewers. They're never going to agree to publish it. I mean, it's always a war, and then internally we're just like, screw it, and publish something else on another topic. So let's go to the hot topics. So go into the hot topics. I mean, where is the disagreements between our colleagues, and how are you helping them on these hot topics, especially with your textbook?
Well, I'm Switzerland, you see. In between all the dental specialties and all the different philosophies, I really have no preference to one philosophy or the other. And I'm not going to tout one method of treating TMD or the other. I speak at many different conferences, many different philosophy conferences, and I listen objectively. I listen and I don't threaten. I'm not threatening to, I think, my dental colleagues, because in the end, I mean, I'm not treating patients. I'm not telling them that they're wrong and I'm right. And I try to show, and help them further understand the TMJ as this central structure, for, like I said, the growth and development of the face and for function. And interestingly enough, just like to go back to your breastfeeding versus bottle feeding, just understanding that the condyle and the eminence, but the condyle have this very thin layer of cells called the fibrocartilage. And that fibrocartilage is what's responsible for the differentiation of the cells and subsequent deposition of bone that will create the condyle, okay? And it's through the growth of the condyle, the growth of the rest of the mandible will occur, And if I take us back to our breastfeeding versus bottle feeding, in order for that growth to occur optimally, the condyle needs to sustain mechanical force, okay? An optimal mechanical force. So let's pretend that these are the gum pads. My fingers right here are the gum pads, okay, of an infant. And in order for an infant to extrude milk from a nipple, from the mother's breast, they need to go like this. If you've ever watched a child do, and there's a lot of action going on with the tongue as well. And when they're doing that with their gum pads, they're actually doing it with their mandibles. So they're activating the fibrocartilaginous cells to divide. They're stimulating them. Okay. Whereas when we have a child who is bottle fed, they just like feebly go up and down, up and down, up and down, and sometimes not even, because, you know, the milk is just going to come pouring out of the hole in the teat. So understanding the role of the TMJ, the role of the position of the disc in the correct place, and the relationship of the disc with the osseous components, and then the relationship of all that with the teeth and the muscles and the neck. I mean, that's a common language, you know. It's like love. It's not, it's like a smile. It's not that like, I'm going to speak English because it's great, and someone else is going to speak French because it's superior, and someone else is going to speak Spanish because that's, you know, whatever. You know, everybody here is talking about their philosophies in their own tongue and not listening to other people, and probably not even trying to understand them or learning their language. But they understand the anatomy, and they understand the function of that anatomy, because that's a common language, right? So like I said, I mean, through my book, I'm trying to help people understand the TMJ, whether it is a dentist that's reading the book or even a medical radiologist. And by understanding not only the function, the anatomy and the function and the biomechanics, but also what is it that is the sequence of events that leads to the dysfunction. And I'm going to talk very briefly right now, just skimming the internal derangements, you know, the disc displacements, you know, I'm going to say something for the dental students in the audience right now. Okay. So, and when I was in dental school, I did not understand what reduction meant. Like, what the hell is this reduction thing? You know, this displacement with reduction, this displacement without reduction. And it wasn't until I replaced the word reduction, okay, with recapture that I understood. Okay, so it's just take the word reduction out. I mean, you have to use it because it's correct terminology, but put the word recapture in your head. Basically, that's what it means. Okay, so when the disc moves forward, if the disc is displaced, when the condyle moves forward, it recaptures the disc and then moves back into the fossa, and then the disc slips back again. That's with recapture, with reduction, disc displacement with reduction. And then if the disc is forward and the condyle is moving forward and it's never recapturing, then it's disc displacement without recapture or reduction, okay? So understanding that and understanding the sequence of events that leads to eventual breakdown of the TMJs, the osseous components of the TMJs, creating the appearances that we see on cone beam CT or even like plain film or even MRI, the degenerative joint disease, the osteoarthritis. That's all mechanics, okay? So your bones, you know, a normal TMJ, a normal condyle and fossa, the surfaces are rounded. And it's like, how can these surfaces be rounded against each other like that? You know, it's because there's a biconcave disc that sits perfectly filling the gap, you know, in between this area. The thin part of the disc is here. And then we have the posterior band and we have the anterior band, okay? So if that disc comes out, that there's a problem, because the disc is supposed to be like a cushion for these bones. It's a shock absorber. As the disc comes out, then we have a situation where now the bones with the movement, with the function, are rubbing against each other and they become flattened. Okay. So we start with functional remodeling where the bones are trying to increase their surface area and they're trying to, you know, dissipate that increased loading over the largest surface possible, either by, you know, flattening or by thickening the bone, sclerosing underneath in the cortex, okay? Subchondral sclerosis. And then when the bone can't take it anymore, it breaks down. So then you get the osteoarthritic changes. So, I mean, I just wanted to describe this because Unfortunately, when we learn the TMJ, when we in dental school or even in our programs, in our specialty programs, we are taught to just identify what they look like, but we don't look at them as a sequence of events. You know, if I see it at the time point 5, okay, or D or whatever, I should know that it went through all these other things, all these other morphologies and all these other dysfunctions before it got to this end stage degenerative joint disease with the osteophyte and with the subchondral bone cysts and the sclerosis and all that. So
to me, the condyle always looked like a loaf of French bread, but then again, I'm always hungry. What would be the next closest joint that it reminds you of? I mean, some people say that it's the only joint that can go forward, backward, left, right, up, and down, that it's completely unique. Is it completely unique in moving 3 directions? What would be the next closest joint?
You know, they're all different. They're all different. This is the only diarthroidal joint in the body. Okay,
the only what?
Diarthroidal. So basically, because you don't just have one TMJ working by itself, you have 2 TMJs and they're connected with the mandible. Okay. Whereas all other joints work independently or semi-independently.
Nice. The TMJ is the only, you're going to spell that for me, the only
diarthroidal.
Arthroidal. Mm-hmm. Joint in the human body. You say you're Switzerland. So, you know, as I get older, you know, I'm 58. A lot of my friends are getting arthritis, rheumatism, things like that. Is this a big factor? Can you see this on x-ray that this person's suffering from arthritis and that's what's causing all their issues?
I mean, you can certainly see the osseous changes. To see the soft tissue changes, you'd need an MRI.
Okay. Soft tissue. And then another thing that confuses kids, especially in school, is maybe she went to dental school because her mom's a dentist and her mom's really big into this. But her mom, as most of her patients are coming there because of migraine, stress, things like that. Is there any CBCT component to looking at TMJ CBCTs that are coming in for migraines and stress and are hoping to get relief from their tension headaches, or are you just verifying that? What are your thoughts on?
You're on cone beam CT. You're just verifying that the osseous structures of the TMJ and any other structures in the craniofacial complex are okay. So you can't really see, actually you cannot characterize any of the soft tissues, the intracranial structures or anything like that. So I guess for that kind of thing, you'd send them to a head and neck, a headache, a pain specialist, not.
So do you ever get MRIs? Do you read MRIs?
Mm-hmm. I do. I read TMJ MRIs.
And do you think someone's going to make an MRI small enough for a dental office, or is that still? I mean, I know a brand new MRI is $5 million from General Electric. Do you see someday an MRI getting down to under $200,000 to go into the dental office?
Well, you never know, really. But the problem with that is that because the technology of MRI is basically a very powerful magnet. It's not about the machine itself, it's about the suite that you have to create. So you have to, in a hospital, the MRI has a suite and the magnet is always turned on. So basically when you walk into that suite, you have to make sure that you're not carrying anything that's ferromagnetic, or else it's going to go projectile missile straight into the bore of the MRI, forceps or whatever it is, anything that's, even oxygen tanks or stainless steel arch wire is ferromagnetic.
I think that's why so many dentists are attracted to an MRI. It's the magnet. So let's talk about your other book, Diagnostic Imaging, Oral and Maxillofacial. Another amazing book. I mean, that's just... congratulations on all that. So how is that different than the first book? So my homies are thinking about, should I get specialty imaging, temporomandibular joint, or should I get diagnostic imaging, oral and maxillofacial?
Well, it depends on what your scope of practice is. You know, if you are an orthodontist, a TMJ specialist, or a sleep medicine specialist, then you definitely want to go with the TMJ book. There's a lot of material that is similar in both books, like the anatomy, for example. The Oral and Maxillofacial book, this was a joint effort with Dr. Lisa Koenig and others, and it's more of a pathology book. So there is the anatomy section, but a big portion of it is any kind of oral and maxillofacial pathology that you might encounter. So maybe if you're a surgeon, a pathologist, a radiologist, or just interested in this kind of stuff, that's the kind of thing that you would be interested in. You want to get a book that has a lot of images of the different types of pathology.
So you're doing an oral and maxillofacial radiology review of the findings. Do you ever suggest treatments or treatment planning or appliance or ortho or anything? You stay completely out of that?
No, that's not my call. That's not my call. I'm not the referring clinician. I'm not the treating physician or clinician. Okay. And like I said, there are so many different ways to skin this particular TMJ cat. And I can't tell the dentist what to do because everybody has their own specialty. Everybody has their own way of doing things. If something needs a biopsy, I'm certainly going to say biopsy. If something needs a follow-up, I'm going to say follow-up. But I'm never going to tell them, okay, so you need to do this type of ortho or this type of TMJ treatment or any of that, because, that's just not right, because I'm stepping over their toes, And when I put this in writing in my report, I'm kind of like tying their hands. So I try to keep it as broad as possible in terms of, I tell them what I see, I tell them what might occur, and then they have to use their clinical judgment and what they want to do for the patients.
You were talking about, your husband's a radiologist, and you've been going to these radiology conventions that cover radiologists from every part of the human body. Do you notice who else do you notice is taking the lead in sleep or TMJ or pain or things like that? What other type of specialties are you seeing that are treating these? Where's the overlap between the dentist doing TMJ, sleep, versus the rest of the radiologists for the rest of the body?
All right. So basically for the TMJ, it's mostly dentists that are working on it. There are some craniofacial pain people, some head and neck pain individuals, ENTs that are dealing with the TMJ, with the sinuses. Some of them are doing some of the surgeries that are necessary for sleep disorder breathing. I think that there are more, in terms of the TMJ, there are so many people looking at it, but only the dentist is really treating it effectively, and focusing on it as a part of the functioning structures. Because like in head, like I said, the medical radiologists and the medical doctors, they don't have an understanding of how our teeth work. They don't have an understanding of how, the function of our masticatory system. So a head and neck radiologist, general radiologist will diagnose a TMJ, but I think that the treatment of the TMJ is mostly a dental one. When it comes to sleep, of course, we have sleep medicine clinics all over the country and all over the world, but it's only the dentist that can fabricate the oral appliance and do the maxillary expansion that's necessary if it is necessary, or mandibular advancement.
For the kids, and again, that's my major focus. I mean, I've already raised my 4 boys. They've turned into 6 grandchildren. In fact, shout out today, little Jasper just turned 2 years old today, and I can't wait to go see how his first 730 days went. But these kids are learning in school, and it's kind of TMJ, I think, is confusing because, with other dental conditions such as a toothache or a sinus problem, it seems more black and white to diagnose and treat a tooth or something like that. This is a very complex issue. Where do you think they should begin? I think we both agree that they should first learn the fundamentals of just all the anatomy. I mean, they just can't learn enough anatomy. Is there any anatomy resources online where you think they teach great anatomy? I've seen some high tech out of San Fran that's well, you said you use Animage. I mean, have you seen?
Yeah, they have a really nice table. I've never. I've seen it, but I haven't gotten a chance to actually do like the virtual dissections and all that. It's pricey though.
How much is it?
Oh, I can't remember, but it's certainly out of my league.
Yeah, I'll never forget. I was lucky in Bishop Carroll High School in biology. Our teacher, Dr. Bushhager, actually drove all the way up to KU, got a cadaver, and drove back down. And we were dissecting in high school, and so we started early on this. But do you still, are you an old-fashioned girl where you still think head and neck on a cadaver is the best way to learn it, or do you think Animage is the way to go, and these dental schools should just bite the bullet and invest in it?
I like the smell of formalin. No, just kidding.
Oh my gosh. And Dr. Bushhager even told us, like when she was my teacher, her and Bernard Butterworth, they were probably pushing retirement, and she actually said that she'd been around formaldehyde so much that she thought that's why she was seeing colors and strange colors in her eyes, and she'd looked into it, and it was from formaldehyde poisoning. So,
wow.
My gosh. But she told everybody that she absolutely had formaldehyde poisoning. But then back then in dental school, before we would cast something, we'd line it with that white insulation paper. Yeah, that's pure asbestos. And then we would heat it up till it was glowing red, then quench it. Always nice to know that you were quenching red hot asbestos in the dental school. But so how would you what advice would you give them while they're in school or even out of school, want to learn more about TMJ? I'd say anatomy, and I would say your
Definitely.
book.
My book has a good section, like about 50 pages about understanding the TMJ. So the first 50 pages are all about understanding the growth and development of the TMJ and how it develops and how it affects the development of the airway, how it develops the occlusion, how it changes the occlusion, how facial growth, it will change as well according to how this TMJ grows. Talks about embryology, talks about biomechanics. So that's the first 50 pages of the book. But I'm going to give you guys some advice, and let me see if I can find my book here. Here it is. So this is what I carried around for the first few years after I finished my radiology residency, and it's Netter's Head and Neck Anatomy for Dentistry. If you don't have this, please go buy it. It's a paperback. It's easy to carry. I took it with me everywhere I went, and it's well marked.
Yeah, so I recognize whenever I marked the books like that, it was always because of a debate. Like I was going to be debating anti-fluoridation on TV or something like that. Why was yours marked? Is it because when you're lecturing, if someone asks a question, you know which page to open up to first?
Well, some of it is more like the more complex stuff. Like I have here the nerve supply of the oral cavity. So, the nice thing about Netter is it's all in like tables. So they've got the nerves and the innervation and what it does and all that. So when it's something that I came back to over and over again, like for example, if I had a case where, the history said something about, I don't know, whatever it is, burning mouth, whatever it is, or not feeling sensation in a certain area, I would go back to this and look at, all right, so for this particular area, what are the nerves that supply it? And this is how you learn. You can't, there's no way you can just like read this like, front to back, you have to apply it every single day in your practice.
I feel sorry for your children because you're so intense. I bet you can see right through them.
Oh, I wish.
So, how would you one of the hardest things for these kids to learn, and it predicts their success rate the most, is who can just talk to people. In fact, I've told so many dentists over the last 30 years, dude, you know what you need to do? You need to go get a job as a bartender on Friday and Saturday night, because everyone's sitting at the bars drunk and you can't talk. I mean, when consultants go into a dental office and they write scripts for them of how to answer the phone, I mean, when you have to teach your people how to talk to another human, you're usually in dentistry or accounting. But what do you have any models where you could pick up some models and show how you would explain this to a normal human who didn't get A's in calculus, physics, geometry, and knows all the, not that when people say the 3 laws of thermodynamics, you say, no, there's actually 4 now, but how would you explain this to normal humans? You're in Orlando. There's a lot of normal humans flying in there from all over the world to see Mickey Mouse. A lot of strange people here.
All right. Well, basically, remember, I'm a radiologist, so by definition, I'm like sequestered in my little cave. Okay.
Are you cloistered? You're a cloistered radiologist?
I'm a cloistered. But I mean, I'm a people person. If you haven't already, figured that out, I like talking to people, and I like dumbing things down. Not that I see that it needs to be dumbed down, but I feel like speaking in a very clear terms, even when you're teaching medical professionals, when you speak in simple terms, the idea sticks. And by not complicating things, like when you give a lecture, you're not having too many points. Find one central point and then just like elaborate on it, so that that central idea sticks.
And the explain it to me like I'm 5 is perfect, because if we were plumbers, it wouldn't make sense to an electrician or a roofer or let alone a dentist or something like that. So nobody knows what you're talking about if they haven't spent 10,000 hours in your field of dentistry. I mean, even my plumber won't do any electrical, and my electrician, and I'm like, well, you know how to fix that. He goes, no, I'm not going to do that. You need a plumber. So I think you should always talk about dentistry to every patient as if they were 5. And it's not dumbing it down. It's just realizing that they didn't put 10,000 hours into this. And
absolutely.
So explain it to me. Do you got any models?
I've got my skull.
Oh my God. Oh, and he looks just like me. I love the hair. Nice, beautiful, bold skull. Explain that blue skull to me like I'm 5.
All right, so let me just tell you what the skull is about. This is my favorite new toy. All right, so this is a magnetic skull.
Now, technically, are you a nerd or a geek? I mean,
I think a combination of both.
Okay. Dania, nerd geek.
Yeah, Dania, nerd geek.
If that's your favorite toy, my gosh, the world needs more of you.
Well, let me show you why I think it's really cool, because it's a magnetic skull. Basically, each one of these bones is a separate structure. So meaning that I can take it apart. Everybody knows you can take the mandible apart. So what, but when you start to be able to take away the zygomas, and you start to take the maxilla and see its articulation with the stuff inside, look at it from the back, and maybe even if you have some time, you can take the 2 maxilla apart, and actually appreciate that you have 2 maxilla and not just one. Okay. And all the structures that are inside, all these little bones that live inside the nasal cavity that make up the inside of your nose. Okay. So so I'm going to speak stupid about nasal resistance. How about that?
Perfect.
Okay. All right. So this is your upper jaw. Okay. As you can see, the upper jaw here, you've got your teeth. You've got the bones that support the teeth. They're called alveolar processes. Okay. And if I were to flip this jaw this way, you'll notice that there are actually 2 bones that are connected in the center. Okay. So when we look at this, okay, we can notice that this upper jaw isn't just the place where the teeth live, but there's also the nose that lives here as well. Okay. So anything that happens at the level of the teeth can also affect the dimensions of the nose. Okay. Because if I were to take this apart and we look at it, the bottom of the nasal cavity, the bottom of the nose is actually the top of the mouth. Okay. So if you are narrow in your maxilla this way, horizontally, there's a very high chance that you're also going to be narrow in your nose. And of course, the term is really transversely, but okay. So when your upper jaw develops, and if it develops subnormally, if it develops small, then your nasal cavity, your nose, is also going to be small. Okay. So that's going to make it hard for you to breathe in and out through your nose. Why? Let's pretend that we have a set of straws here. You have a smoothie straw, you have a regular straw, and you have a coffee stirrer. Okay. Try to breathe in and out through each of these straws. And which one would be the easiest one? You tell me, Howard.
A bong.
A what?
A bong?
A smoothie. Which one would be the easiest straw to breathe through? The smoothie straw, the regular straw, or the coffee stirrer straw?
The biggest, roundest straw.
Right. Well, not the biggest one. Like if you were to take a PVC pipe, you wouldn't be able to breathe through it because, but certainly the smoothie straw would be easier. So if your upper jaw doesn't develop properly and your nose doesn't develop properly and it's small, then sucking air through your nose through a very small straw is going to be so difficult, just as it would be sucking through air through a coffee stirrer straw. Okay. This coffee stirrers that actually have a whole,
yeah,
okay.
Absolutely.
All right. So yeah, I mean, that's how I would explain that portion of it.
I have a question where you're at there. Some orthodontists say that you can only expand the jaw with a rapid palatal expander, at a young age, 6 or 7. But some people are claiming they can do that on adults. Do you see, how does your anatomy, can you expand the upper palate and the nose volume as an adult without surgery, or?
It would have to be surgically assisted.
It would have to be surgically assisted.
There are some appliances out there that claim to stimulate the production of undifferentiated mesenchymal cells. They call them stem cells. I'm not sure, really. I haven't seen studies that show long-term changes with those. But in the end, I mean, I can't really recommend treatment, and I really can't tell people what to do. But if that rocks their boat, and they're trained to do that, and they see results, then all the power to them.
Well, the camp that says it can't be done after the suture is formed is they're saying they're just tilting the teeth. They're not really expanding the mandible, and you have to do a surgery. Can I ask the most bizarre question? Selfishly, just for me, I know no one cares about this, but I can't find the answer. My boys were, we're 3rd generation wrestlers. My grandpa and we just love it. And then, so that leads to like boxing. I grew up on Muhammad Ali, and now it's UFC and all these great boxers. What I don't understand as a dentist is that you can punch a person in the nose all day long, but everyone knows if you catch him right at the end of that mandible from the side, not straight on, but if you clip the side of that mandible, it's lights out. So something electrically is happening. And the other place you see is in the temple, and I don't want to go to the temple because, a lot of people think that but anyway, what do you think electrically is going on? Where because you just took off that mandible like no problem. Why do you think if it gets torqued to the side really fast and hard, and in fact, a lot of times they get knocked out just like a short little punch, but if you land it just perfectly, you don't have to reach back and swing your whole body, but if they hit it just perfectly, it's lights out. Do you think that's an electrical issue?
I'm not 100% sure about that.
Have you ever thought about this?
But I'm thinking as you're talking, and I'm thinking it has more to do with the actual position of the mandible. It may have something to do with the position of the neck, and the sudden movement. We've got a lot of stuff going on in this real estate right here. You've got your carotid arteries, you've got the spinal cord, you've got nerves, cranial nerves coming in and out, the skull base. So it may be, I'm not 100% sure. it may be something to do with that. Now, with that said, in martial arts, there are certain points that if you were to touch them or to, deliver a punch or like a quick whatever, let's just like in the movies, I'm sure you've seen, where they do, I don't know, something with two fingers and the person's like out. In Ayurveda, Ayurveda is a form of therapy, coming from the yoga traditions and all that. There are points called marma points, okay? And these marma points are known to be connected to different parts of the body. So for example, if you have issues with your heart, with emotions, whatever, you'd stimulate the marma point, which is right about here, So I'm thinking that there must be some kind of a, if you're going to think holistically, there must be some kind of an energetic field that has to do with that, that kind of impact, I really can't explain it to you anatomically right now. You would have to ask a sports medicine person.
Obviously, like a rear naked chokehold. Obviously, the carotid arteries, their throat, they can't breathe or get blood flow. But it just seems to me that is just looks like an electrical issue. It looks like someone just turned off the lights. And I want to ask you another thing. There's 8 billion humans. They're all the same. It's only one species. Our species has less diversity than about any other species. So a big red flag I always pick up on is when they are thinking different thoughts all around the world. And you've lectured around the world. You even went to school in Saudi Arabia, Harvard. Their classes, it's always international. I bet what percentage, but anyway, Harvard's, it's all international. They come from everywhere. Where do you see the diversity of TMJ thought around the world as you move from the Americas to Africa to Europe to Asia, Antarctica? I know most of their work is done on penguins and doesn't apply, but do you see
they have TMJs?
Do you see any variants, or big variances or yes, different schools of thought? Well, let's talk about that, because because that's got to be the most interesting.
And I'm just going to say it like it is, and I don't mean to offend anybody, but it seems that in the U.S. and other places that follow the U.S.'s teachings, there's a lot more rigidity and a lot more. This is the way it is, and this is how you do it. Whereas if you go to South America or to other places in Europe, you'll see that the clinicians are more willing to incorporate some of the more adjunct therapies. So things like osteopathy, chiropractics, oral myofunctional therapy, without feeling threatened that their turf is being, stepped upon. And that's how I see it. I'm physical therapy, for example. It just seems that many people here in the U.S. are very, one-track minded in terms of this is the way it is and that's all there is, and then that's not everybody.
In Arkansas, they took a license away from an orthodontist because he brought in a hygienist. He didn't want his patients to have to go to the dentist, have the hygienist take him off, come in for his check, then go back. So he just brought the hygienist and said, well, we'll just take him off, clean your teeth, then do your check. And they're like, you can't do a cleaning at an orthodontic office. It was like, it's just, I agree. I agree. They're very rigid. So what advice would you give Americans? How do you get an American to loosen up besides alcohol? Yeah, I've always thought that every lecture I went to, getting my FAGD, MAG, all that stuff like that, the 1 or 2 hours in the bar at 10, I learned more from the guy than during his all-day lecture, and I would just sit there and say, well, why didn't you say that at the lecture? And he's got his three-piece suit on and his PowerPoint. Yeah, just lighten up, dentist. Just lighten up. Well, that's good advice for anyone.
If I say this, and this is meant for all human beings, not just Americans, any human being, let go of your ego, tame your ego and just don't let it get the best of you, because the ego makes us emotional. and makes us angry and defensive. But if you listen objectively and you just step back and try to walk a mile in the other person's shoes, you'll be surprised what you learn.
Well, you were talking earlier about yoga. I mean, you got a huge fitness background and certified in Pilates, yoga, and spinning. Do you think I always thought Bikram Yoga, and I was so upset when he got into trouble and had to flee the country or whatever, because I just love Bikram Yoga. I don't like the other yogas, because with Bikram Yoga, you knew it was going to be 26 poses twice, and you were going in there, and it was just so easy to follow, and you could just get in the zone. But then now I have to go to other yoga classes, like trying to follow some cheetah around a jungle, and she's jumping around and going this. I just find it's just too exhausting. It's not even fun anymore. But did you find did you ever do Bikram versus
It's too hot in Florida for me to go into a Bikram class. I can just like step outside and and do whatever yoga class there, with the humidity and so I see how that would be fun, if you lived somewhere like Boston.
but do you think yoga's a good for the mind too? When you said, relax and, let go of your ego, do you think yoga is a big mental, probably maybe even more mental than physical, as opposed to other sports, like say playing racquetball or something?
Well, it's really, okay. So let me take a step back and say it's not a sport, and it's not like a gym class. It's really a way of life. So if you really go into the yoga philosophy and you go into the teachings of yoga, and I'm not even talking about like, a religion or anything like, because it's not a religion, but it's basically there's a code of conduct, how you treat yourself, how you treat others, and part of it is not harming. Okay. And non-harming is not only not harming other people, but not harming yourself with negative thoughts, with internal chatter that is unnecessary, that brings you down. And I think that is a common affliction in many of us, where we ruminate and we go back to past experiences or maybe things that we did that we regret. And we keep bringing that up in our heads internally and, just regurgitating it and going back and forth on these thoughts. And that keeps us from living in the moment, rather than, if you're always there, always in those thoughts, then you're living in the past. And if you're worried about the future, who knows, if it's going to come or not. But so yoga helps you be in the present, be in the moment. Okay. Not stealing. So it's not just stealing somebody's possessions, but not stealing these moments from yourself. Like if you were to, once again, just sit and worry about this or that, or think, I wish I didn't do that, you're stealing this time from yourself. So it's a lot of things. And the practice itself, the actual movements, what we call asanas or poses, those help tame those traits, within us, so that we find a bliss inside of us. And I did, let's see, when I was going through my residency, I did about 200-hour certification, my oral radiology residency, that is a gazillion years ago. And recently, because of COVID, I was able to complete my 500-hour certification because everything came online. And then also, I'm completing my yoga therapy coursework as well. So yoga therapy is it's basically life coaching with a twist, quite literally, So you're trying to help people figure out how to get rid of the past if they have past issues, post-traumatic stress disorders. We have a lot of issues now with COVID and others, a lot of trauma in the world, a lot of suffering. So if we through yoga therapy, and through helping people liberate themselves from these negative thoughts that just keep on coming. Also chronic disease, yoga therapy helps people who have cancer, who have diabetes. And the central idea is that these negative thoughts and attitudes is what causes the harm to our bodies. By storing these negative thoughts inside of us, we are creating a fertile ground for the development of these chronic diseases. So, I don't know if I digressed from your original question.
No, when I podcasted the president of the American Dental Association just about a month ago, Chad, I was saying, well, what's the biggest thing on your radar now? And he says it's actually not even COVID. It's the sudden spike of suicide among dentists. And on Dental Town, the longest thread going right now since COVID is actually suicide. And I cannot believe some of the people that have checked out. I mean, it just looked like the all-American, mom with kids, husband, everything's just perfect. In the middle of the pandemic, she just checks out, and several. And so, mental health. I mean, who cares about oral health if you don't have mental health?
Right, exactly. And it's harder to get rid of mental health issues. The physical issues, the physical ailments, the acute physical ailments we get over. But then we get to a point where, if we keep these negative thoughts inside of us, they never go away. And you know what? They don't just stay with us, they transfer to the next generation through epigenetics. So, certainly, I mean, there are certainly there's a lot of people suffering. I mean, in general, life is full of terrible things. I mean, here in the US or anywhere in the world, we have a high incidence of abuse and, child abuse or marital abuse. And these things, they harbor these feelings, these negative, destructive feelings of lack of self-worth, lack of self-confidence, not to mention, just the fear and the anxiety and the depression.
Well, I mean, nature is brutal. I mean, someday the sun's going to, as it slowly burns out, will engulf the whole Earth. Even if we survive that, the whole Milky Way is going to go through a black hole. I mean, all of nature is pretty brutal. I'm always shocked when people are tell me about all the bad things that happen in human history. I'm like, God, you can just watch an anthill. An anthill is brutal. Just get on the ground and watch it. Have you ever seen ants fight another ant? Have you ever been sitting there where two tribes of ants are going after? I mean, they line up. I mean, it's all of nature is just brutal. It's very brutal. So just relax and enjoy the ride. And you said something that I thought was very profound, where you talked about where one of the biggest secrets is just be humble. And my gosh, dentists could learn so much from so many people. Humility is a big part of increasing your comprehension, isn't it?
Absolutely. Absolutely. The thing is, here's the thing. I mean, if you go to the fountain with a cup that's already full, then you're not going to have any place to put more. If you go in with a perception that you know everything, then, where's that openness? Where's that vessel that's going to receive more? You go to the well with an empty cup and, and bow your head to your students, because the students are the best teachers. So definitely humility, like I said, it's taming the ego. It's work. It's hard work. I'm saying this now. I mean, this is years and years of really, really hard work, self-improvement and self-thought and contemplation of one's own emotions.
I want you to talk about that, because so many dentists, they'll start talking and they'll say, I want to be really, really successful. And I'm like, well, what does that mean? And he'll say, well, someday I want to have 10 offices. I'm like, well, what does 10 offices have to do with being successful? And it seems like the common traps, I don't know, that'd be my question for you. That's what I'm going to, when I get done ranting, I'm going to say, do you see anything different, mental issues with dentists versus the rest? But they always live above their means. I mean, they're always stressed out, but they can't drive a Ford, they can't drive a Prius. It's got to be a Benz or a Range Rover. They can't have a 3-bedroom, 2-bath. They got too much house, too much car, and their wife, if it's a radiologist, probably didn't buy a $5,000 Gucci purse. She probably bought one from Target. I mean, I don't know. Maybe you're a purse. Maybe that's your weakness, purses. But I
No,
just
it's
think
books.
dentists,
My
it's
weakness
books.
is books.
So so my question is, what do you think makes would be the definition of a successful dentist? And do you think a lot of their stress is brought on because they just financially live so far beyond their means? I mean, again, everything in financial planning, they'll never talk about financial planning. If you don't get married, you won't get divorced. Then you won't have alimony. If you don't have kids, kids are expensive. I mean, so they go out and they get married. They have a whole litter of kids. And they build a mansion, big cars. They can't go camping at the lake. They have to go to Hawaii or take a cruise. And then they want to know why they're running 45 hours a week stressed out of their mind. And at 50 years old, they still have debt. And I'm like, dude, so what is a successful dentist in your radiology yoga mind of yours?
One whose colleagues and patients and family regard him with the utmost respect and pray for him after he's died.
Wow. I'm going to have to get that in writing. That was awesome. Now you'll know how slow a typer I am. A successful dentist.
Because really, what is all this stuff?
Someone who, say it again, a successful dentist is someone who,
I mean, whose colleagues and friends and patients and family regard him with the highest respect. And, when he dies, they pray for him. And whenever he's mentioned, he or she, I should say she, because I'm a she, right? These individuals, pray for that dentist or pray for that person.
That is beautiful. That's the best I've ever heard. A successful dentist is someone whose colleagues, friends, and patients hold them. Would you say them in their highest?
Yeah, he or she. It's S/HE.
Patients hold them in their highest respect and pray for them after death.
Mm-hmm.
That's beautiful. My mother loved that. But I want to ask you, since you added religion to oral radiology science, I've noticed some dentists, their whole career has always found it bizarre that actually around here it's a lot. They'll say, well, how can Gordon Christian be the main scientist, over the years, yet he's very religious? How do you reconcile a scientific mind that's only based on facts and a religious mind that's only based on faith? How do those two things come together?
Well, I'm Muslim, so my faith basically tells me to look around at nature and contemplate God in everything. And contemplate all the signs of his existence, the planets and stars, the animals, the plants, the turning of the earth around its axis, the sun, the moon, just looking at everything and seeing him in everything. So it's not separate for me, to be scientific, to see him even in the smallest details of the cell organelles, and his hand and all these things. It's certainly not separate.
I've podcast interviewed 1,500 dentists, and you're the only one that reminds me the most of my oldest sister, Mary Kay, who she entered the nunnery. She entered the nunnery straight out of high school. She's been a nun 10 years longer than I've been a dentist but anyway, my gosh, seriously, when you talk, it's like I'm talking to my older sister, Mary Kay, or sister.
Do you like
Anna
her?
Yeah, you know what I love about her? You know what I love the most about my oldest sister? Is that in their cloistered convent, when they die, they bury them in the backyard, right? In the garden. They're like on a 6-acre deal. The average life expectancy of everyone buried out there is over 90 because they don't have any stress. And whenever you go visit her, when they're all together, they're always giggling. They're always laughing. In fact, I wanted to write a book, a non-dental book called The Giggle Factor, because I noticed right out of the gate, how come when I lecture in a very poor country, everyone's laughing and everyone's giggling, and then you go to like Japan, Germany, the United States, and and it's like everybody's just, wow, they're just wired up tight, and it's like, holy moly. And then it's like, I wouldn't trade the giggling in Kathmandu and Rio de Janeiro to live in Seoul, Tokyo, or Berlin. I mean, I mean, my gosh. I mean, how long is lunch in your neck of the woods in Miami.
Well, in Orlando, I mean, if you go to a conference, lunch isn't that long, you know. But if you go to a conference, for example, in Spain or in South America, it's about 2 hours long, because it's about not just about let's just get food in us real quick and go back to sit in a dark room, you know, for a long extended period of time.
And then the afternoon's more interesting, because when you lecture in Spain or Brazil or all those places, when they go have a 2-hour lunch, they're always going to have some beer and wine,
and they talk,
and then they come back and they're even more loose and happy and lucid and talking. And I feel sorry for people who are born, raised, and died and never left the United States, South Korea, Japan, or Germany, because they don't even know. I don't think most Americans even know how uptight they are until you go see a whole nother culture that's like, dude, you take yourself too serious. Just relax, chill, have fun, you know. But
right.
I really like that.
And you wonder why so many people have TMD.
Yeah, exactly.
Just, you know, you're, I probably shouldn't say this, but I guess
it's Dentistry Uncensored. Rant it. Come on, you feel a rant, let it out.
So in yoga, basically, you know, the issues around your mouth are related to issues around your anus. So if you're, you know, over here, basically, you also have issues with your digestion, and you have with your actual elimination. So in the yoga therapy world, Ayurveda. Well, I mean, bringing it back to that subject, you know, one of the things I want to do one day, you know, probably like when I have time, is to write a book about yoga for the TMJ, or yoga for TMD. So basically helping put these two worlds together that I have, you know, the dental world, the scientific world, and the more holistic world, and try to help my dental colleagues understand that their orofacial pain patient, their sleep disorder breathing patient, you know, their TMJ patient, did I already say TMJ? Their orthodontic patient, you know, all of these people have issues, especially if they look at little girls, you know, these days, they've got a ton of issues. And they all have issues, and these issues affect not just their faces and their necks, but the rest of their body as well. And part of I believe, the success of one's treatment is to deal with the whole person and not just the physical manifestation of disease. What is it that caused that disease? What is that deep internal knot inside that person's heart or that person's body that manifested as the cascade of events that led to the TMD, you know?
And why is it always caused from the mom and not the dad? That's what I can't figure out.
What?
This internal knot of stress and all that. You always get that from your mom, not your dad. Dads are perfect. You know that. Ask your husband. Everything that went wrong, you always blame it on mom. Your kids must be very young, but no, I'm just kidding. But hey, my gosh, I think you're just a wonderful person inside and out. My gosh, from radiology to yoga, what an amazing mind you have. And it was your textbooks are amazing, and I can't believe that you spent my gosh, hell, we're coming up on 2 hours. Thank you so much for coming on my show today and talking to my homies about all things from TMJ to the whole mind and body and spirit. What a wonderful person. If you ever want to come back on the show, I'm inviting you to come back before this one's even over. That's how wonderful you are. Thank you so much. Dania Tamimi, Oral and Maxillofacial Radiologist at Beam Readers. Have a rocking hot and wonderful day today.
Thank you so much. It was a pleasure.